My pleasure again to, and thanks for the invitation for coming to this particular session. So we're with my co-moderator, who I presume is virtual, Dr. Crisci. We'll kick off this next section on new clinical considerations. I do find this interesting in the sense that, we sort of presume that the standard way we manage lung cancer in screening is the appropriate thing, but there is a balance in how we investigate and get to a final decision, and delays in the pathway can be quite detrimental, particularly as we know size of tumor resection has such an impact on prognosis. So I guess the first talk is exactly on that, delays in treatment and perceptions of patients and physicians. So if we can ask Dr. Zhu to come and give the first talk. Thanks very much.
Hi, good morning. All right, so as discussed, the topic's about time to treatment. So we all know that if lung cancer is caught early, the chance of survival increases dramatically, and later stage that goes down quite a bit. This data is from the U.S. This is what kind of kicked off the topic. Every week of delay on stage 1 lung cancers increased the risk of death by 3.2%. And this is another study looking at a veteran population with a cut point of 12 weeks, as seen the darker group versus the yellow group. With more delays, there was decreased survival. And shown again with T2 sized lesions, this is a group out of Austria, showing the same effect of decreased survival with increased delay. Now, there's no standard recommendation for treatment, and here are a few guidelines, if you will, of what the appropriate time to treatment is. So the American College of Chest Physicians said, with patients with known lung cancer, the delivery of care should be timely and efficient. British Thoracic Society said surgery should be within 8 weeks with a visit to a respiratory specialist. And back in 2000, the RAND Corporation said diagnosis of lung cancer should be established within 2 months of abnormal radiography, and treatment should begin within 6 weeks of diagnosis. So that shows you that it's really amorphous about what the time is, like what should we be looking at and what the time is. So the aim of this research was to get a number. What is the time to treatment for our population for our clinical stage 1 lung cancer surgical patients? Look at significant patient factors and predictors that led to increased delay. And also a unique part is to look at what the surgeons thought was the time to treatment. And there was a bonus thing because COVID happened in between, and we saw if COVID, the pandemic, increased delay. Now, this is how we calculated the time to treatment. It's the pathway to diagnosis. In the purple, you see the date of first suspicious CAT scan. For some people, this is the only CAT scan they ever got. For other people on screening programs, it's the CAT scan that led to further intervention, like a biopsy or a PET. On the pink, we see date of first biopsy, so when they tried to get tissue sampling. And then with the blue, you see the date of surgery. So we took out the days in between, and then we have one time from suspicious scan to biopsy, one from biopsy to surgery, and then the total from scan to surgery, which is the time to treatment, TTI. So this is just the surgical part. Dr. Henchy just mentioned the radiation comparisons, but this is only looking at surgery, clinical stage 1, and no evidence of recurrence before. And study population, 638 subjects, median age of 70. Typical, it's almost like a demographic of Manhattan, so with more of a white and non-Hispanic population. Mostly college educated and mostly former smokers. So with the 638 participants, the median time from the suspicious scan to surgery is 84 days, almost 3 months. Interquartile range of almost 2 months to 5 months. And some of the significant factors, Black race, 32 days more than white. Education, you see 11 days. Vascular disease, 12 days. Asthma, 20 days. And liver kidney disease, 14 or so. And then the part from scan to biopsy, education, nodular consistency part, non-solid lesions were the highest here. Vascular disease, liver, kidney disease. And then the last part, biopsy of surgery, race, nodule consistency, and surgical extent. And now when looking at the multivariate, race, again, showed up, and vascular disease. So these were independent factors that were associated with delay. Now, the bonus finding of COVID pandemic, we saw that there was a significant side from the scan to biopsy part, 4 days. And anyone who was around during that time can imagine like all the canceled biopsies, very few biopsies, 2 biopsies a day instead of 6 that Dr. Yankelevitz did, people doing the wrong COVID tests, things like that. And then on the surgery side, there was no delay. Actually, it was even less after the pandemic hit. So the takeaway from COVID is that the delay was on the radiology side, not from the surgeons. Now, we asked the surgeons, 15 I-ELCAP surgeons, what's the average time to treatment? How long can patients wait? What factors affect this and what factors contribute to most delay? And let's go through this. So they said the median one was 4 weeks from diagnosis to surgery. So this is the second half of biopsy of surgery. And the actual was 37. And this was exceeded by 63% of our participants. So it didn't really match what happened. And then what's the longest a patient can wait? Surgeons said 8 weeks. And this was exceeded by almost 30% of our participants. And do you believe every week increases the risk of death? 5 said they somewhat agreed, and then everyone else was either neutral or they disagreed. And finally, what factors affect this characterization? Large nodule size, histology, and central nodule location. All right, so this is a small glimpse of the qualitative interviews. This was actually the first thing that we did regarding the study. So we did 104 in-person qualitative interviews with I-ELCAP participants at least 6 months post-treatment. Some of them were 4 years out or 3 years out. Some were newly 6 months. And we asked them, was your surgery delayed? And 89% considered their surgery, 86% considered their surgery timely, and only 14% said it was untimely. And then with the qualitative research, we took all the themes and sub-themes, and we abstracted 7 themes and 20 sub-themes. And the significant ones with the delay side, people who said their surgery was untimely, they were able to name a specific source of their delay. They know what happened. Someone said they delayed their surgery because they wanted to watch The Walking Dead season premiere. COVID-19 pandemic as well. And these are not the themes, but these are things we picked out of the interviews. What were the causes of surgical delay? So from the untimely group, 7 out of the 15 said the COVID-19 pandemic, obviously. And then also the insurance for PET scans. That was the next most common one. Now, from the group that was not delayed, we teased out things that they revealed in the interviews. And 8 of them said they had a personal scheduling conflict. And I guess they didn't consider that a delay of surgery. Preoperative clearance, some people had to do other tests before, everyone does, but some people had to do more than others, I guess. And also the physician scheduling conflict. From the surgeons, patient comorbidities, their scheduling operating time, that's operating room availability has always been an issue. So that's what they thought were most common sources of delay from their side. So conclusion, stage 1 patients in our group faced longer delays than expected by their surgeons. Black race and vascular disease were the independent factors associated with increased delay. COVID-19 didn't really affect delays overall, but it was significant on that first part from radiology, from scan to biopsy. And patients should be aware of their delays. They should know, no, it's not time to mess around, let's get surgery. And directions for future research quickly. Qualitative research, we'll talk more about that at the ISLC. TTI surgery versus radiation, and also future directions, screening versus incidental findings, and surgical approach. Thank you.
Thank you, Dr. Zhu, for this interesting investigation into a very important issue, especially for the patient's point of view. There is some question from the audience.
Did you distinguish cases that were screen detected versus symptom detected?
Yeah, that's like the direction for future research. This was discussed at the ATS actually. People in a screening program versus incidental findings. But I guess also that's another one, like the symptomatic group, I guess. Yeah. We did not look at that yet.
Please introduce you when you do a question, please. Other question?
Fred Granis, there should be a natural experiment here. The American College of Chest Physician, astonishingly to me, recommended delay of treatment of stage 1 lung cancers during COVID. Is anybody working to look at the effect of that delay on survival of lung cancer in the United States?
Yeah, I think there's a lot of research, but it was kind of like retrospective. They were like, there was this delay from that recommendation, shut everything down, and then they kind of looked at retrospective data. But I think that's coming down the pipeline as time goes on. We'll see more and more of that research. But there is preliminary findings from the literature that I've seen.
Could I just ask if you were able to, in the short term, did you measure any impact on stage from the delay? From the first scan that they had to, just prior to treatment? Do you have any data on that?
Everyone was clinical stage 1 at first, but obviously some people were upstaged after. We have the data, but that wasn't part of this, I guess. But yeah.
Just as a comment, through COVID, there was a period in the UK where we were doing on-the-day CT scans on the day of surgery. CT scans. So the first time we had a comparison between the baseline CT, and a comparable modality just before surgery, and we could see that 1 in 5 people migrated stage in their investigative pathway, and after 62 days, it's 1 in 2. So there's a real impact, I think, the delay. In the UK, we have a 62-day standard, and most patients come to a surgeon on day 55 of that, and then it takes another 30-odd days to get them into surgery. So I think delay is a real issue.
I'll just add in something quickly. They were doing the CAT scans to catch COVID back then because you could see the ground glass on the periphery. 1 or 2 patients found their lung cancer from those CAT scans from getting COVID.
And did you have any? What sense did you have about why race and vascular stuff was associated with delay? What was the?
For vascular disease, I'm thinking there could be like preoperative clearance, things of that nature, and then maybe if they're less healthy, they would go consult radiation oncology, and then they would come back for surgery. Race is obviously a tricky issue, but there's other factors that go into it as well, I think.
Thank you, Dr. Zhu. Now, the second speaker, Dr. Zhang, who spoke about quality of life considers of lung cancer treatment.
Good morning, everyone. It's a pleasure to present our results in the study of quality of life after early lung cancer treatment. I have no disclosure. And a small proportion of patients are diagnosed with lung cancer at early stage, thanks to the implementation of CT screening. There's an increase in the overall survival, which makes quality of life an important consideration when choosing the optimal treatment. And according to a systemic review in 2022, it was shown that for surgical patients, their quality of life initially declines and then returns to baseline in 6 to 12 months after surgery, while for SBRT patients, their quality of life stays stable. And the utilization of VATS and sublobar resection reduced the initial decline in quality of life after surgery. So our study wants to assess the differential impact of treatment options on intermediate to long-term changes in quality of life. And first, we are comparing between SBRT and surgery. And next, we'll be comparing between robotic and VATS surgery. We are using 5 quality of life measures, the SF-12 physical and mental component score, which measures the physical and mental health of the patients, and the functional assessment of cancer therapy, the lung cancer subscale, which asks about lung cancer related symptoms. And then we are also using PHQ-2 and GAD-2 for depression and anxiety. To look at the comparison between surgery and SBRT, we look at 778 I-ELCAP patients, which only including Mount Sinai sites with first primary clinical stage 1 non-small cell lung cancer and with maximum diameter less than 3 centimeters, who underwent either surgery or SBRT. And after excluding those patients who died and who had adjuvant treatment and those who don't have quality of life forms, we have 679 patients included in the analysis, and 94 of them had SBRT. And here, let's look at the baseline characteristics of those patients. We found age pack years higher for SBRT patients and more current smokers and less never smokers among SBRT. And also there's less adenocarcinoma and more squamous cell cancer among SBRT patients. And obviously there's more comorbidities, especially for SBRT patients for cardiac and vascular disease, and COPD, diabetes, and asthma. So in order to see the trend of the quality of life outcomes, we applied physical health and mental health against time after treatment. And as we can see, there's a shift of the trend of physical health for surgical patients at around 2 months. So we propose to use a piecewise linear mixed effect model to model the change of quality of life outcomes, which assumes that there's a decrease of quality of life outcomes in the first 2 months and then a recovery period after 2 months. And we also included the covariates like age, gender, BMI, pack years, smoking status, nodule size, pulmonary function, and all the comorbidities in our model. And this figure here shows the physical health for surgery and SBRT patients estimated by the model. And the blue curve represents the score for SBRT patients, and the brown curve represents the score for surgical patients. The x-axis here represents the months after treatment, and the y-axis is the physical health score. Here, a higher score means better physical health. And we can see for surgical patients, their physical health declines in the first 2 months and then recovers after 2 months. While for SBRT patients, their physical health didn't change much at the beginning and declines after 2 months. And here, this figure shows estimated mental health. As we can see, both groups' mental health started above the population average prior to treatment and improved over time. And then we also look at depression and anxiety scores specifically, and they show the similar trend. And we tried adjusting for the comorbidities and other covariates in our model, also tried propensity score matching, but we still was not able to match the baseline physical health score for surgical and SBRT patients. So we decided to better understand the difference between those two groups, we stratified our patients into two groups. The first group of patients with less than 2 comorbidities from the left side of the graph, and the other group of patients with 2 or more comorbidities, which was shown in the right. And it's worth noting that for SBRT patients with less comorbidities, their physical health performed better compared to those patients who had more comorbidities. However, we also need to be aware that the number of SBRT patients is way less among the group of patients with less than 2 comorbidities. So overall, we found improved mental health, depression, and anxiety for SBRT and surgery patients in the first year after treatment, and worsening physical health within the first 2 months after surgery, and worsening physical health over the first year after SBRT. And now let's focus on the surgery patients only. Let's look at the comparison between robotic and VATS patients. And we look at 671 I-ELCAP patients, including both on-site and outside sites. And after excluding those patients who died and had a adjuvant treatment and those who don't have quality of life forms, we had 600 patients included in the analysis, and 161 of them had robotics. The maximum nodule diameter was found to be higher for robotic patients, and there's more squamous cell cancer among robotic patients. And also there's more lobectomy among robotic surgery and more sublobar resection among VATS. And here it shows the estimated physical health for robotic and VATS. And the blue curve here represents the score for robotic patients. The brown curve here represents the score for VATS patients. Overall, both groups of physical health declines in the first 2 months, but then recovers pretty well and improved above the population average at the end of 12 months compared to baseline. And here is the estimated mental health score. They both started above the general population average prior to treatment and improved over time. And also we look at the depression and anxiety score specifically, they also showed a similar trend. And lastly, I want to present the factor LCS score, which asks about the symptom of lung cancer related. And it's interesting to see there is deeper decrease for robotic patients in their factor LCS score in the first 2 months. However, both groups, the factor LCS score improved in the following 10 months. So overall, we found immediately improved mental health, depression, and anxiety after surgery for both robotic and VATS patients. And we found no significant difference between robotic and VATS patients in terms of physical health after surgery. And there's a deeper decrease of lung cancer specific symptoms and well-being for robotic patients in the first 2 months. And to comment on the results, I think first we should be thinking about the results in the perspective of looking at the changes over time for SBRT or surgery patients, in addition to looking at the differences at certain time points between those treatments. And we need to be aware that the sustained poor physical health outcomes of SBRT patients were likely not due to the treatment, but overall poor baseline health. And to better help the recovery of patients, supportive care should be given to SBRT patients in a more sustained period. And in terms of the comparison between robotic and VATS, the absence of significant difference in the trajectory of physical health between those two groups suggests both methods can be considered equally effective from a physical recovery point. And I think that may mean that the choice between them can be guided by more other factors like surgeon's perspective. And the immediate mental health benefits after robotic and VATS highlights the significant psychological benefits of early lung cancer treatment. And it's also interesting to see the advantage of that in symptom management, especially in the first 2 months. And it would be good to hear some of this from the surgeon's perspective to help us with future research. Thank you.
We got any questions for Dr. Zhang? No, I think in the interest of time, then we'll move on to the next speaker. The necessity of a tissue biopsy. I think this is a video. I think we're playing tissue biopsy and staging from Dr. Malapelle.
Hi everyone, my name is Roberto Malapelle. I'm the chair of the Victim Molecular Pathology Lab at the Department of Public Health from University Federico II Naples. And today I'm really glad to be here with you, try to discuss the need of tissue biopsy. For this, I will really thank the organizers for inviting me. Those are my disclosures. And if you open the door of an anatomic pathology department, you can find different types of biomaterials like histological samples, cytological samples, and liquid biopsy. And as you can see in this slide, cytological samples is in the center part of the upper part between histological word and liquid biopsy, because cytological samples represent the bridge between these two words. In fact, in my opinion, we need not find a war between tissue and liquid biopsy, but we need to try to find a marriage between tissue and liquid biopsy, because if you analyze cytological samples, when we receive this type of samples in our lab, after a centrifugation, we are able simultaneously to obtain a pellet that we can use for morphological analysis and to make the first step to diagnosis, and then the supernatant that we can use as an integrative part with the morphological evaluation for the molecular analysis. And this is a source of liquid biopsy because we are able to retrieve nucleic acids and the other type of biological information that we need to use to molecular evaluation of our patients. And management of this type of samples is really ancient in the anatomic pathology department, because coming from 1858, and we know how to manage all these type of body fluids also in the context of a tissue-based approach. And this is really relevant, in particular when we have a complex landscape like as non-small cell lung cancer patients in the advanced stage, in example, in which we need to test a plethora of different biomarkers, as you can see in the left part of this slide. And one of the most important approaches is the combination of tissue and liquid biopsy to enlarge the patient's population that we are able to treat with target treatment or to select better for immunotherapy. In this slide, you can see a dashboard of a next generation sequencing platform in which you are able to see different profiles coming from DNA extracted from tissue of these patients, in which we are able to see that there are these different targetable alteration, but also different other type of additional information, like as an example, the second case in which you have the combination of an P53 mutation and EGFR mutation. And it's really important if you have a complete view on the morphomolecular assets of these patients, because you are able to correlate if this mutation is clonal or not. For example, if you have the estimation of percentage of neoplastic cells in these patients and you see the map of 30%, this is a clonal mutation if you have 60% of neoplastic cells, but if you have 100% of neoplastic cells with a mutant allele fraction of 30%, this means that you have a subclonal population of this mutation. Another place in which the combination of information coming from molecular words and tissue is really important is immunotherapy, because today the only approved biomarkers in small cell lung cancer patients, in example, to select patients for immunotherapy, is represented by an immunohistochemical evaluation by using PD-L1 expression. And it's really important that when we conduct this type of analysis, we see the tissue for PD-L1 expression evaluation, and we need to remember that within the PD-L1 expression groups, we have different type of biological molecular information also in terms of addiction for the different type of patients, because as independent, the higher expression of PD-L1 with the presence of an EGFR mutation example. And if we divide the group of patients in relation to the PD-L1 expression, you can see that we can have different type of assets. And if you are able to see the tissue in a patient showing more than 50% of neoplastic of PD-L1 expression in a context of more than 80% of neoplastic cells, and you have a 0.1% of KRAS mutant, in this case, this is a subclonal alteration, and the clinical value of this alteration is not shown in clinical trials. For this, the indication is completely different based on the visual inspection of the tissue that you are able to see in relation to the percentage of neoplastic cells. Another place in which the combination of information regarding tissue and liquid biopsy is really useful, in example, is in the radical resected stage 1/3 non-small cell lung cancer patients. Because if you have the tissue in your hand and you are able to stratify the mutation by using next generation sequencing in this tissue, identify and track mutation, you can use this mutation in bloodstream to follow during the time the evolution of the tumors and also the evolution of the treatments for this type of patients. And in particular, you can try also to combine different type of technologies, because in example, you can use next generation sequencing on tissue and then digital PCR on liquid biopsy until the resistance disease. And at the resistance disease, you can recollect the tissue for a next generation sequencing wide analysis to identify the resistance mechanism for our patients. Other type of resistance mechanism as histological transformation is only possible to analyze this type of resistance mechanism by using tissue, but another time by combining tissue and molecular information coming from tissue, genomic DNA extracted from tissue, or cell-free DNA, in particular ctDNA coming from liquid biopsy, is another time really useful to understand the biological evolution of the lesions that you are treating for. And we have different type of resistance mechanisms. Some of these are identifiable by using molecular analysis in tissue and in liquid biopsy, and some other of these other mechanisms, like as an example, MET amplification, HER2 amplification, are today analyzing by using tissue-based approach. With the evolution of the methodologies, in example, by using atomic force microscopes, like as the reading of your vinyl, you are able, combining this with mathematical modeling, to analyze the difference from structural point of view and morphological point of view between tumor component and non-tumoral component. And this is really useful when you are trying to tailor your molecular approach on tissue. And another time, if you follow the international guidelines, you have one of the ways suggested that is the complementary approach between tissue and liquid biopsy. And as we can see from this nice experience of Sanjay Popat group, that if you use the combination of information coming from tissue and liquid biopsy, you are able to identify different type of different set of mutation, private set coming from liquid biopsy, private set coming from a tissue biopsy. But if you consider altogether this information, you are able to identify a higher number of targetable patients by using tissue and liquid biopsy combination information. So as conclusion, we can use the first slide, but with a modified title, in which you can see that we have the need of a marriage between tissue and liquid biopsy.
Then we go to the fourth presentation. The Professor Lucchi, who speaks about mediastinal sampling or dissection. Why, when, how?
Good morning, everyone. I replace Professor Lucchi. I'm Maria Giovanna Mastromarino. I come from Pisa. It's my pleasure to be here. And I bring you the greetings of Professor Lucchi, who unfortunately couldn't be here for institutional obligations. I'm going to talk about mediastinal sampling or dissection, why, when, and how. I have nothing to disclose. Intraoperative nodal assessment, it's a critical component of the surgical treatment of non-small cell lung cancer. Indeed, the nodal assessment is often cited as one of the leading benefits of surgeries compared to stereotactic body radiotherapy for early stage NSCLC. The extent of lymph node involvement in patients with non-small cell lung cancer is the most important prognostic factor and influences therapeutic strategies. Despite this, what constitutes adequate intraoperative nodal assessment is subject to much debate. So what can we consider adequate when we talk about lymphadenectomy in early stages? The extent of mediastinal lymph node assessment during surgery is still controversial, and there is no consensus about mediastinal dissection or mediastinal sampling. When we look at the lymphadenectomy strategy, what we have to prefer, a station-based strategy or a counted-based excision? Historically, the evolution of lymph node mapping began with the 1978 report by Neruker and later revisions. However, the first systematic guidelines and standardized definitions for intraoperative lymph node staging in non-small cell lung cancer has been proposed only in 2006 by the European Society of Thoracic Surgeons. Quickly about the definition. The sampling is the removal of one or more lymph nodes guided by preoperative or intraoperative findings. Systematic sampling means a predetermined selection on the lymph node station specified by the surgeon. When we talk about systematic nodal dissection, all the mediastinal tissue containing lymph nodes is dissected and removed systematically within anatomical landmarks. At least 3 mediastinal nodal stations, but always included subcarinal, should be excised as a minimum requirement. Beside the mediastinal nodes, the hilar and intrapulmonary lymph nodes are dissected as well. In lobe-specific systematic nodal dissection, the mediastinal tissue containing specific lymph node stations are excised, depending on the lobar location of the primary tumor. It's mandatory to remove at least 3 hilar and interlobar nodes and 3 mediastinal nodes from 3 stations in which the subcarinal is always included. These are the nodal stations involved for each lobe-specific nodal dissection, so we can go rapidly. So, independently of the tumor stage, in 2006, ESTS recommended a systematic nodal dissection in all cases to ensure complete resection. Removal of at least 6 lymph nodes from hilar and mediastinal station, 3 and 3, unblock resection, when possible, of the upper mediastinal nodes on the right side, and an unblock resection of the lower mediastinum, including the fatty tissue from the diaphragm to the subcarinal space. Any visible nodes in front of the superior vena cava and or posterior to the trachea should be removed, while on the left side, removal of the subaortic, paraortic, and inferior paratracheal lymph nodes is minimally required. However, in early stage non-small cell lung cancer, the minimum number of lymph nodes necessary to consider lymphadenectomy as complete is not clearly defined. The group of Pascal Thomas from Marseille considered that lymphadenectomy as complete where more than 10 lymph nodes from at least 2 different mediastinal levels were removed. Conversely, Wu from Taiwan considered that lymphadenectomy as inadequate for proper staging and local control of the disease if less than 15 lymph nodes had been resected. From the other side of the world, the long-standing American College of Surgeons Commission on Cancer Guidelines advocated for at least 10 lymph nodes to be sampled intraoperatively. However, on the basis of the limited evidence, these guidelines were updated in 2021 to instead recommend sampling of 3 mediastinal and 1 hilar nodal station, similar to the recommendation from the NCCN. Regarding a station-based strategy, the International Association for the Study of Lung Cancer advocates for a site-specific sampling, while the Union for International Cancer Control recommends sampling 3 hilar and 3 mediastinal lymph node stations, as previously stated by ESTS in 2006. In recent years, the controversy between a station-based strategy or a counted-based strategy is emerging more and more. Last November, it has been published a cohort study that evaluates Okay. Regarding the controversy between a station-based strategy or a counted-based sampling, last November it has been published. It has been published a cohort study to evaluate the updated American College of Surgeons station-based definition. So the adherence to station-based sampling was associated with improved recurrence-free survival, while count-based sampling was unassociated with RFS. Adherence to either station-based or count-based guidelines was associated with improved overall survival and higher likelihood of pathological upstaging. These findings were most pronounced in tumors less than 3 centimeters, highlighting the importance of guideline concordant sampling even in small tumors. The study supports station-based sampling minimums for early-stage non-small cell lung cancer. However, the marginal benefit compared with counted-based guidelines is minimal, as you can see in Kaplan-Meier survival curves. Going back to the traditional controversy between mediastinal dissection and mediastinal sampling, a pivotal randomized controlled trial dating back to 2011 revealed that sampling is adequate specifically for a clinically node-negative disease. In fact, there was no significant difference between the two groups regarding both overall survival and disease-free survival. But it's important to recall that the patients were randomized after an invasive mediastinal staging. Thus, the trial results may not be generalizable to patients staged radiographically or those with higher stage tumors, such as T3 and T4 tumors. Recently, systematic meta-analysis found higher morbidity following lymphadenectomy than after sampling, in terms of an increased operative time, increased blood loss, recurrent laryngeal nerve injury, an increased shallow thorax, and an increased rate of bronchopleural fistula. Another issue in clinical cancer is the nodal upstaging. The rate of occult pathologic NC disease in clinically N0 patients can reach up 10%. Furthermore, Bill demonstrated the presence of skip lesions in 1/3 of patients with nodal upstaging. These results abrogates the entire notion of sequential nodal sampling, such as sampling mediastinal nodes only after that hilar disease is identified in early stage non-small cell lung cancer. The risk factors associated with occult lymph node metastasis are a tumor size greater than 2 centimeters, a PET-CT uptake more than 5, high-grade adenocarcinoma histotypes, the serum CL level, a tumor-invasive component size, and the invasion of visceral pleural or lymphatic. And what about sublobar resections? With increasing use of sublobar resection for ground-glass nodules, which seems to have a low incidence of nodal involvement, the extent of lymphadenectomies is an emerging controversy. The very recent, highly anticipated Japanese trial published on Lancet last year showed that segmentectomy was associated with improved survival compared with lobectomy for patients with early stage, less than 2 centimeter peripheral non-small cell lung cancer. It's very important to underline that nodal sampling was robust in this study because systematic or selective lymph node dissection was mandatory in both groups. Although the 5-year relapse-free survival was similar between the two groups, the rate of patients with local relapse were twice as high for segmentectomy compared with lobectomy. Thus, sublobar resections could be associated with higher rates of inadequate nodal sampling. This finding highlights the importance of an adequate nodal sampling, which will continue to be critical as segmentectomies may become the standard of surgical care for selected patients with early stage NSCLC. However, for GGO, mediastinal dissection may not have a significant impact on either staging or survival. In fact, in a propensity match study comparing mediastinal or only dissection for stage 1 and SCLC appearing as mixed GGO, the mediastinal nodal involvement was found in only 9 of 329 patients with solid dominant lesions, but in none with part-solid lesion. The extent of nodal dissection was neither a risk factor for survival nor predictive of nodal involvement. So, to conclude, the diagnostic significance of regional lymph nodes is clear, but the prognostic significance still remains controversial. Although systematic lymph node dissection has been the worldwide standard, it may not be the best option in all cases, such as for part-solid GGNs. An emerging theme is the centrality of station-based sampling as opposed to a counted-based strategy. Further studies are needed to analyze the possibility to determine the extent of lymph node dissection individually for each case. Efforts should be made to increase the implementation and concordance of guidelines in general practice to improve the quality of surgical care in lung cancer patients. Thank you.
Well, thank you very much. Any questions, please? I want to just try and bring it, we're a bit short on time, but just trying to bring it back to the screening world. So given there is some morbidity from lymph node dissection, should we be doing lymph node sampling dissection for clinical stage 1A screen detected lung cancer?
It depends if we have a solid nodule or a ground glass. For a solid nodule, it's better to continue to perform a mediastinal sampling, not a mediastinal extensive dissection. Conversely, for the part-solid ground glass opacity, it's a sampling, it's enough. These are the very last evidence.
You know, the rate of lymph nodes in non-solid nodules, positive lymph nodes, is virtually 0%. And even with part solids, when it's small, solid component, it's 0% that you get lymph nodes, positive lymph nodes. So to our thinking, what we've talked about, and we've been presenting this to our surgeons, and our surgeons are really starting to move in this direction, is that they're not even doing lymph node sampling. They're doing no lymph node because they're not going to find any. And this is not based on our data. This is based on a review of all of the world literature on non-solid nodules, and but there really are just no lymph nodes. They're not metastasizing. So it brings the question of, can we start to even take this further? Can we start thinking about, when we look at these peripheral solid nodules, how well are we able to predict beforehand whether they're going to have lymph node metastases? You know, and at some point, you know, if you can start saying the chance of a lymph node metastasis is, let's say, 1%, you still need to do it for something that has a 1% lymph node metastasis. I mean, these are the kind of things that I think are going to become the more and more challenging aspects for the surgeons to think about. At what point do we say we don't need to do these dissections or sampling? How do we guide it by our ability to start predicting whether or not there are going to be nodal metastases? Because I think at some point you get to the point where you can say chances are so low, it's not worth the morbidity, even to do sampling.
I mean, the interesting thing to me, sorry, just to come back on that bit, is, you know, if we believe the morphology on CT is predictive of the pathology, then it makes sense, doesn't it, that a GGO or a sort of in situ disease or minimally invasive won't have lymph nodes, but the solids, in relation to what you just said, if you had a solid stage 1A screen detected lung cancer, would you want your lymph nodes sampled?
Well, I think you need to have much more data on the location of and maybe the cell type, and understanding the morbidity of doing that additional lymph node sampling. I think those are important questions.
Sorry. Okay.
Maurizio.
Can I just say something about, We don't have very hard evidence in favor of lymphadenectomy for solid nodules, especially in the screening setting. We only have that old trial, I-ELCAP trial. However, we have that large database of the I-ELCAP investigating the value of R uncertain resections. And we have seen that 90% of those are resections where the lymphadenectomy was inadequate. And this is associated with lower outcomes, worse outcomes. So I think lymphadenectomy is still something you should carry on if you are dealing with a solid nodule for sure. I don't think it really carries a significantly higher morbidity in expert hands. So you need to be doing that. This is my comment.
Okay. If I can add something, we have also to look at the neoadjuvant therapies. Let's look at ADAURA indication. If the resection is concerned incomplete, then the patient, even if he has EGFR mutation, he will not get the adjuvant therapy. So I think we will be obliged to do a complete, surgically relevant resection in the future for this purpose, for purpose of adjuvant trials that this is obligatory to do, the good resection, lymph node.
But I think a lot of those statistics are for all sizes. I think we need to be much more size specific in what the value is. And even the ISSC data, I don't think is size specific enough. So I think we need to refine those criteria.
To reply to the first question from the surgical point of view, we can discuss about anatomical resection or wedge resection for GGO part solid, but lymphadenectomy, at least mediastinal sampling, it's mandatory. This is the difference between surgery and radiotherapy, because the rate of nodal involvement is not 0%, but at least from surgical database, it's at about 2 or 3%.
Well, I think we've hit a controversy, so we better finish on that. But thank you very much to my co-moderator, Roberto, and to everybody that's participated. Thank you very much.